Welcome, I'm Gina Montagna. Today we'll be talking about artificial hydration and end of life. I'll be reviewing a problem, discussing relevant research, discussing the benefits of artificial hydration, harms of artificial hydration, when we should offer hydration, plan, the implementation of the plan, potential barriers, internal research, and ethical considerations. The problem in the PICOT question format. In the end-of-life care, does clinician-assisted hydration via PEG, IV, or subcutaneous administration compared to no hydration affect symptom management within the last weeks of life? So what does the research say? When implementing evidence-based practice, there needs to be evidence. The research I conducted includes a rapid critical appraisal of the works that most fit the PICOT question. I evaluated the validity, reliability, and applicability of each of the studies to provide the best evidence-based practice in this presentation. Although I searched various databases, the most current reviews, studies, and trials I found valid, reliable, and applicable came from the British Medical Journal. There is a need for further data collection, analysis, and publication around the benefits and burdens of artificial hydration in end-of-life care. Next, I will be reviewing the findings of my research evaluations, including the benefits of artificial hydration, potential harms of artificial hydration, when to offer artificial hydration, and a plan to aid in data collection to further the research surrounding the issue of artificial hydration at the end of life. The benefit of artificial hydration. One is addressing the patient concerns, poor health, uh, improved sleep, poor appetite, increased anxiety, worsening dry mouth, sunken eyes. Patient may believe that hydration can help in all of these symptoms. Maintenance of renal perfusion, prevention on the accumulation in the body from drugs leading to delirium or opioid toxicity. When there's no contraindications, there is no evidence of increasing survival rate for use of artificial hydration and no evidence of symptom improvement except for having a higher global deterioration scale, GDS, which is the measure of cognitive decline. So there is some increased cognition with the use of artificial hydration, but that's really the only symptom that we have evidence for to support the use of artificial hydration within the last 7 days of life. Some of the burden and harms that can be caused by the use of artificial hydration at end of life. Regarding the death rattle and terminal restlessness, in the last 48 to 25 hours, there is no effect of artificial hydration use on the occurrence of the death rattle. With a 24-hour prognosis, there is some effect in the terminal restlessness, increasing when using artificial hydration. Increasing hydration increases edema symptoms and advanced disease. No change in the status to dying patients with cardiac symptoms, edema, dyspnea, cardiac failure. Symptoms can increase if in these diagnoses. The worsening of vomiting, worsening respiratory secretions. And finally, there is a theory that has not been proven yet that dehydration does have palliative effects, such as releasing ketones and having an effect on the patient's symptoms, contributing to analgesia and sedative effects, but there is no supporting evidence for this theory at this time. When to offer artificial hydration. As of March 2023, there are currently no plans for further randomized control trials for the use of artificial hydration at the end of life. When to offer hydration. When there is symptomatic dehydration, thirst, or delirium, malignant hypercalcemia, when not contraindicated, such as with evidence of fluid overload. We should discuss with the patient and their loved ones the uncertainties relating to the benefits and risks of clinically assisted hydration, considering the physical, psychosocial, spiritual, and social factors that are critical to the patient and the family. Plan. Collecting measurable data, including the patient population information, age, sex, height, weight, socioeconomic status, government supported, family supported, independently wealthy, or any combination, ethnicity, religion, spiritual involvement, in patient preference, social and family preference, that differs from the patient's preference, this setting, whether it's in the home, hospital, or inpatient hospice center, or a nursing home. The objective, the objective patient information we should collect is the primary hospice diagnosis, the contributing diagnoses, the ability to swallow if a study was previously completed or reported, symptoms reported by the patient. The subjective patient condition will likely need to be used, as patients often become nonverbal within the last days of life. So we should be using measurable tools such as a pain ad scale, the modified Borg dyspnea scale, the assessing the ability to swallow if a swallow study was not previously completed, the level of consciousness. We can use the Glasgow Coma scale, delirium. We can use the nursing delirium scale. Interventions. We need to record fluid regimens, the amount, the route, frequency, the type of solution. We need to compare with the standards of care, such as encouraging oral fluids when safe and consistent mouth care being provided, in addition to the use of IV fluids. Assessment of the outcomes, recording symptoms and their degree prior to the artificial hydration, and every 12 hours once hydration is initiated and in use. I think that is a good time frame to see if there are any effects of using the hydration or not. We need to do an evaluation, categorizing and evaluating collected information in written format using statistics, comparing findings and identifying patterns to benefit future research in the field. And we need to present, disseminating the information, presenting the findings to disciplinary groups within the organization to address performance improvement measures for consideration. We need to seek to have the findings for the process for data collection published by medical and/or nursing journals in the palliative and hospice fields. Strategic plan implementation. We need to assess the organizational readiness. We can use the Six Sigma methodology for improving designing, monitoring, processes to minimize eliminating waste while optimizing satisfaction and increasing financial stability. The role of our leaders at every level must embrace the change They must role model and support the change. Potential barriers. Overcoming cultural barriers within the organization. Um, Some of these that I have seen are IV hydration is only for cancer patients. We don't do IV hydration in the home. These type of statements are going to end the topic of discussion, but are not true. We as an organization should promote providing the best care to each patient, regardless of their sex, religion, income, or socioeconomic status. And we need to continue to do this by taking responsibility for asking for guidance when we are not sure of the company's policy or stance in a situation. Now that we have reviewed the benefits and burdens of artificial hydration, we all have the tools to educate each other, the patients, and loved ones. Educating staff on artificial hydration options and contraindications allows us to provide education about the options and begin an individualized health plan for the patient, always leaving open the understanding plan may change based on the patient's changes physically, emotionally, spiritual, and their preference. The rollout will be one department at a time, appointing champions at the different levels of the organization as point persons for each department, overseeing and assisting when necessary to ensure the evaluation, implementation, and recording of data is conducted consistently with ownership belonging to each department's manager or assistant manager where applicable. Sources of internal evidence. Most of the internal evidence we collect will be from the patient's medical records. No patient identifying information will be collected. The information should be collected and entered into the F drive file within 48 hours of a patient passing. When the patient is identified with a probable prognosis of less than 7 days, the primary nurse will use a checklist to discuss hydration preferences with the patient and or the family. The co-considerations. Although are not experimenting on patients, we are using information that can be identifiable when put together. We will need to meet with our legal team as we are a Catholic institution. We should consider discussion with the Archdiocese of Rockville Center. If we determine that consent is preferred or required, I would suggest that we add the form to the admission packet so that as I think this would be the correct time to obtain consent on every participating patient. Questions, feedback? Thank you.